All right, welcome to the Let's Talk series. The Let's Talk series is a 30-minute video discussion between myself, Dr. Becca, Dr. Amanda, and a local practitioner who understands pelvic health on topics pertaining to women's health and wellness. This series was created to help women navigate their pelvic health wherever they are on the path of womanhood, to advocate, navigate, and collaborate together with a holistic team of allies. Pelvic health healing is multidimensional, and the best outcomes occur with a team-based approach. So we invite you to tune into our monthly series to learn more about your pelvic health and engage with our community partners. So welcome to Dr. Lauren Spivack. Today we will be discussing pelvic pain and how Dr. Spivack kind of got interested into pelvic pain, and a little bit more about the different etiologies of pelvic pain, and talk a little bit more about endometriosis and pelvic floor dysfunction. But Dr. Lauren Spivack joined the Department of Obstetrics and Gynecology at Rowan University in August of 2020 to lead the newly established Rowan Center for Chronic Pelvic Pain. Yes, we're very excited to have her locally. Dr. Spivack is a fellowship trained in minimally invasive gynecologic surgery. Her medical interests extend to the medical and surgical management of chronic pelvic pain, fibroids, endometriosis, interstitial cystitis or painful bladder syndrome, and benign adnexal masses. And I'm sure she will tell us about what all of these things are for our listeners. She's trained in advanced laparoscopic and robotic assisted laparoscopic surgery and sees patients in both Stratford and Washington Township offices in New Jersey. She's a graduate of the University of Pennsylvania and earned her medical degree from Sidney Kimmel Medical College, Thomas Jefferson University. Dr. Spivack completed her OBGYN residency at Cooper University Hospital, where she served as chief resident, followed by her fellowship in minimally invasive gynecologic surgery with a focus in chronic pelvic pain at the University of Rochester Medical Center. So we're so happy to have her back local to South Jersey in the Philadelphia area. Dr. Spivack is passionate about caring for patients with chronic pelvic pain conditions, knowing that many of those patients have struggled for years with unrelenting and undiagnosed pain. She's also passionate about caring for transgender patients, specifically as it relates to treating chronic pelvic pain and performing gender-affirming hysterectomy and oophorectomy surgeries. Fun fact, she also is fluent in Spanish. So if any of you out there
we can do the whole interview in Spanish.
Yes,
exactly.
That is just another, little feather in her cap.
Exactly.
So thank you so much, Dr. Spivack, for joining us. Why don't you, give a little bit more kind of background into yourself and how you got interested in pelvic pain and how you started the whole Center for Chronic Pelvic Pain.
Yeah, absolutely. So thank you so much for introducing me. I am Lauren Spivack. So I'm actually from the area. I was born and raised in Wilmington, Delaware, and then have been living in Philadelphia for the better part of 15 years outside of my couple years of training in Rochester, New York, but came back here because this is where my community is, and also because I really felt that there was a need for a practitioner that could see patients for chronic pelvic pain. So my interest kind of fell into my lap in a way. So I completed my OBGYN residency at Cooper, and then decided I did want to pursue a fellowship, more so because I wanted to focus on minimally invasive gynecologic surgery, which is laparoscopic and robotic surgery, to become more proficient and do more advanced surgeries. So the fellowship that I was accepted into at Rochester has a specific focus on chronic pelvic pain. They actually have a chronic pelvic pain center where that was a national referral center. So I didn't know I was interested in it at all, and initially was actually very intimidated by chronic pelvic pain, because as a chief complaint, it's something that gynecologists do see all the time, but actually if you speak with them often dread it because it's a common visit, but it's so difficult to treat. And this is mostly because we don't initially really get trained or have the tools in our training to know how to treat it. some of the more common conditions. So once I went to Rochester and started being mentored, I was seeing the patients regularly, hearing their stories, and started really understanding the diagnosis and the treatments. And so then it became incredibly rewarding to me, and I started really kind of embracing chronic pelvic pain. At the same time, I was also dealing with some chronic back pain issues and had this relatively new medical condition that I had been diagnosed with, adult onset type 1 diabetes. So it really set me up to appreciate the patients that I was dealing with and what they were experiencing in a new way, making me really, I always want to hear patient story, that's part of it, but really being able to empathize with them in a more personal way and really try to find ways to make their everyday more tolerable and improve their quality of life and just decrease their pain. And then most importantly, really validate their experience, because so many patients just have been not listened to or not validated. And I find that is probably 75% of the treatment or even treatment success is people being heard and validated. So my passion really kind of blossomed from there during my fellowship. And so I did decide upon finishing fellowship that I wanted to, of course, do my minimally invasive GYN surgery, which includes treating patients with pelvic pain, but really focus on also the medical management of pelvic pain as well. So I took the position at Rowan, and really there was a really great need in the South Jersey area, at least from what I had seen and known from my time at Cooper. So the chair at the time was really encouraging and helped me to develop a center for chronic pelvic pain at Rowan that I kind of decided to spearhead, so to say. And so we set that up with the aim to see patients with various chronic pelvic pain conditions, evaluate them, diagnose them, treat them, and then refer them as appropriate. So it's certainly not a comprehensive center like my goal would be at some point. To have, but that's part of it. You got to start
Right.
small. So my
Exactly.
goal is to have other practitioners, physical therapists like yourself, which I'm developing relationships with, nutritionists, acupuncturists, really all for a more holistic, comprehensive type of care for pelvic pain, since we know that that is what they need. But for now, I've really been working in the past couple of years on developing a referral network, so that I really know how and where to send my patients for the best treatment that they can get. But definitely a work in progress, but incredibly rewarding.
Yeah, for sure. I know that just speaking to what you were saying with, part of your role and a lot of the work that you do is just validating people's experiences. I've so many people who come into our office after years and years of just being, maybe turned away or not listened to. And it really does like take a toll on your like quality of life and mental health, because they're like, I thought I was crazy. And we'll get people who,
or I was the only one.
Yeah.
Like this loneliness too that comes with it.
So to feel like, no, it's like I'm listening, I understand, I believe you, and this is how I can help you. It's like such a joy to be able to work in that kind of space with people. And they're even in the US, I don't know how many kind of pelvic pain centers there even are, just a need to kind of address this.
Yeah, are there a lot of pelvic pain centers like the one in Rochester?
There aren't a huge number of them. There certainly are. I wouldn't say there's tons and tons, but there are definitely some pelvic pain centers that are doing really amazing work, and ones that are developing actually. In Rochester, New York, there's another pelvic pain center that's developing. Here in South Jersey, Virtua is working on developing more of a pelvic pain center. I think as it's becoming more and more known as an issue, especially even just pelvic floor dysfunction, but pelvic pain in the knee, places are developing centers. How much they are more of the comprehensive centers, because Canada has some amazing centers, at least that I've learned about through some of my conferences. So it sort of depends what someone calls a center, so to say, but I think it's becoming more, there's definitely more of a need. There's one in North Carolina through UNC. So it depends. Places where there are big MIGS surgeons often are going to have chronic pelvic pain because it's so overlapping.
And I think one thing that I have learned being in the pelvic health world now for like 8 or so years is that there's doctors and gynecologists and urologists and urogynecologists that specialize in pelvic pain, but the word pelvic pain can encompass so many things. So I've had some clients who said, oh, I went to this doctor at this hospital system and they said they worked on pelvic pain, but really they worked on, maybe like yourself, like endometriosis, but really the client was or experiencing bladder pain and they needed somebody who understood that experience that they were having. And I think that's why so many things surrounding pelvic pain can feel so disjointed for people. Very similar to how our bowel clients feel. That they're like, I went to a GI because it's my GI system.
Yeah.
But some GIs only look at your belly button to your throat and nobody's looking at your behind and the bottom of the GI system. So it seems that there is such a need. And again, another reason why we're doing this is to kind of help link people to like who you are in the chronic pelvic pain world or in the pelvic pain world and kind of go from there. So
and I think one of the really important things is that, so in terms of the conditions that I see patients that come to me, I may not know how to treat every single thing, but like you said, the fact that I'm looking at it, I mean, pelvic pain is really, chronic pelvic pain is defined as 3 to 6 months duration of pelvic pain from the belly button below.
Right.
And so that obviously incorporates a huge number of systems. So I see people, yes, for endometriosis, but pelvic floor dysfunction, abdominal myofascial pain, interstitial cystitis, IBS, different neuralgias like pudendal neuralgias, vulvodynia. So although there are certain things that I may not be as comfortable seeing, like IBS, for example, I have a couple of treatments, but I can at least know in terms of hearing a patient's story, which way I may think their diagnosis is going. And also the fact that so many people have several things at once.
Yeah.
So it's not just IBS, because we know these conditions coexist together. So I think that being able to not just say this is the one thing that you have versus there might be 3 or 4 things and I can treat you and help you with these couple, and then I'm going to have to kind of help coordinate your treatment elsewhere because of the different systems involved. But that's part of what in my OBGYN training, traditionally, you don't get a whole lot of training about some of these pelvic pain conditions. You think more so you have some endometriosis, fibroids, ovarian cysts, and then it kind of stops. There's not a ton of other, maybe infection, pelvic inflammatory disease caused by some infection, but not sort of the lesser known things that are actually some of the most common things people present with. So my fellowship gave me all those tools to learn how to link what I was hearing from patients and what was going on. Because I distinctly remember as a resident, I wish I could go back and treat, 1 or 2 of the patients that I said, I just am not, I don't know what's going on. Your ultrasound looks fine. I can't figure it out. I don't know. And kind of that, now I know exactly what was happening. It was her pelvic floor, so.
And to know that like birth control or placing an IUD is not the end all be all. Cause I think that's when people come to us with pelvic pain symptoms. They're like, well, I went on birth control or I started this or started that, but like nothing has changed. And they feel like that's like their last stop when really there's other providers like yourselves that can, jump in and read those pieces of the puzzle.
Exactly.
Yeah.
And so I think there's nothing wrong at all with a general OBGYN who doesn't see pelvic pain, 100% fine, because there's a need. But I think what's important is to know about these conditions and or know how to refer to a practitioner that can help. Because that's where people get stuck, where it's like, I don't really have anything else to do for you. The pill didn't work. And actually it had nothing to do with their cycles.
Right. And that's one of the things that I think is very important to us, and why we wanted to even, start this whole path and that sort of thing, is because we really pride ourselves on, people come into our office with chronic pelvic pain. And I think as like a young therapist, you might be like, oh, okay, like you want to help this person with
Yes.
every single thing, but you're the we might be the person, to address the pelvic floor dysfunction, but knowing that, maybe they need to, see you for some injections, or, maybe they are a candidate for like a laparoscopic surgery, while we can kind of manage all the pelvic floor conditions. And then having them work with a nutritionist or a dietitian and acupuncture, really being the people that for so long have gone into a doctor's office and just been told, I don't know, or just this medication, and then walk out the door. For us and yourself to be able to kind of, truly walk along the path with them and say, this is what I can help you with. And then these are the people that we're going to bring in to kind of really address, you as a whole, and not just try to, mask the symptoms or get the symptoms to go away, but to really kind of address all of the underlying things. And as you stated before, it's usually not just one thing. There's many different things that, one person can't address at all. So
yeah, I totally agree. And I mean, just as to the point of how complex it is, my initial visits with patients include a patient, when they call for a pelvic pain appointment, if they're able to identify that, I have them fill out a packet of information that gives me, a 15-page packet that really helps guide my understanding of what's going on with their pain. But then the appointments are 45 minutes to an hour, that initial appointment. It's really a consultation, which in the medical world, when appointments are 15, maybe max 30 minutes, that's unheard of. But it's been great at Rowan. They've really supported me to do that, because that's the only way to really get a thorough sense of all the different pain generators and do the exam. And then the very important part of explaining to the patients with imaging and or with images that I pull up and other things, why I think what I think. And for, in terms of what you guys are doing, which I can't, I refer so many patients to physical therapy. It's just crucial. A lot of people have never heard of pelvic floor physical therapy. They don't know what the pelvic floor is. So giving that as an introduction, just to start at the visit, and then giving them some videos that they can watch about the pelvic floor, all that is so important, the education component. And so it requires a lot of time and realistic expectation setting, especially if someone's coming in with however many years of pain, that what the goals are for reducing pain, not always eliminating it, depending on what we find. But that just goes to how complex of a condition it is.
Exactly.
So what do you typically see a lot in your office? Like what do you want people to kind of know about pelvic pain? What are a lot of the diagnoses that maybe you kind of work with on a day-to-day basis?
Yeah. So certainly outside of pelvic pain, I see your general GYN appointments for any kind of issues. But as it relates to pelvic pain, I am referred a lot of patients that ultimately have endometriosis. So they've been dealing with very painful periods and other symptoms that go along with endometriosis, but have not been treated or had a surgery to confirm that or remove that. So that's a big thing I see patients for. Most patients with endometriosis also really do have pelvic floor dysfunction. So I usually am able to identify that as well. Some of them, it's just not just, but it's pelvic floor dysfunction is their primary thing going on when they come in, or, abdominal myofascial pain, where they've just been having this persistent abdominal pain and no one can sort of figure it out, or these episodes of stabbing pain. The different words they use obviously kind of help guide me. I do see patients with interstitial cystitis as well, and I can treat that. I see pudendal neuralgia as an etiology of pelvic pain, and other neuralgias too, ilioinguinal and iliohypogastric, usually as it relates to potentially some sort of incisional entrapment, or other nerve entrapments, but sometimes they may be primarily from the muscle spasm. Vulvodynia, is another thing. Once I exclude other infections, I often treat people for vulvodynia. And then there are other things that cause pelvic pain that are a little more obvious, like large fibroid uteruses. So I will do surgery to remove the fibroids or remove the uterus to help resolve their pain. I see patients that have, so adnexal masses, what that means is basically cysts on the ovary. So that can be in the form of endometriosis or just large cysts that can cause pain. Usually that's more acute in onset, that someone might have developed a cyst and they have a lot of pain from that. When it's chronic, that's typically more endometriosis related. So those are the different things that I see patients for from a pelvic pain standpoint. And then for treatment, there's medication treatment depending on what the condition is. I do injections, so different trigger point injections. I do pelvic floor Botox, which is an off-label use of Botox, but for pelvic floor dysfunction that hasn't responded necessarily adequately to physical therapy or as an adjunct to physical therapy and medication. And I find really good results with that, and that I learned in my fellowship. I will do bladder installations for interstitial cystitis in the office, and then surgery for endometriosis, for ovarian cysts, for fibroids, and then all the other commonplace GYN stuff.
Yeah. I mean, I think it's great that, we work with all the different providers who do some kind of pelvic pain in the area. And it does seem that everyone has their little specialty of, I just do injections for IC and installations, or I just do injections for pelvic pain. But the fact that you can kind of look at it from like an even larger perspective with still a direct focus of pelvic floor dysfunction is great to know that, like, as you build respect and trust with providers, that if all of a sudden they were saying like, it's still not going away, for you to say, okay, well, look, we can do a surgical kind of exploration, or I think that a surgery would be best for you. You already have that trust and you've already kind of like walked with them. So I think that's a really great superpower, basically, that you're able to provide, that you've done everything from the more minimally invasive in-office procedures to, a minimally invasive laparoscopy. Because it does feel disjointed for many people of like, I have this doctor for this and I have this doctor for that. And this, so just to have that nice, like a smaller community, that does feel really helpful to people too.
I totally agree with that. And it's nice to have that skill set, because I did, for example, see a patient recently who already has diagnosed endometriosis and young, was at the point of just such frustration with her pelvic pain that she just wanted a hysterectomy. And she came to me, and she has had a lot of physical therapy and different medication, and so we talked about the different options, and that hysterectomy did not need to be on, that was not something that needed to happen and may not have anything to do with her pain. And so we were going to, her pelvic floor was definitely significantly tender and tight, and she had pelvic floor dysfunction that was being worked on with physical therapy, but with minimal sort of result. Endometriosis that was confirmed. So we talked about, listen, maybe we need to do another surgery. Well, so she was willing to do that, but in the meantime, we got approval for the pelvic floor Botox. So I said, well, let's do both, because they're both really pain generators. I don't know which is kind of the more
the driver of it.
Yeah. And so she had the pelvic floor Botox a couple of weeks ago, and I was really hopeful that it would work, but you never know. And she came in to see me for her surgery setup for her endometriosis. And she said, where has Botox been all my life? My pain is like so much better. And I had started her on also a neuromodulator medication, and her pain was so improved. I said, do you want to proceed with surgery, or would you like to hold off? And she said, I want to hold off. And so that was just sort of this amazing thing where I could offer her that, but we were able to do something else that actually, I think her muscle dysfunction is primarily, potentially, her primary pain generator. It's not to say the endometriosis isn't part of it. It is. I'm treating her for that. But we were able to, I'm not, needing to do surgery on everyone at all. And so when she kind of had that option that maybe I don't have to have surgery because my pain feels way better with this non-invasive procedure, that's the plan we made. That felt really rewarding to me, just to be able to help her in that regard, in a way that 4 years ago, before my fellowship, I never would have been able to offer something like Botox, because I didn't know about it, or how it worked, or anything like that.
Yeah. Well, and to think that you know, if she wasn't working with you, if she had gone to another provider and just said, I want a hysterectomy, and then she probably would have had the hysterectomy and still had all the same
pelvic pain.
Right.
pelvic pain symptoms.
Yeah.
So I think, you know, being able to truly identify what are the underlying causes, and it might not just be one thing, like you said, where the endometriosis you guys are addressing, but really kind of getting to the root of the pelvic floor dysfunction helped to, you know, alleviate a majority of her symptoms, and at the end of the day, spare her uterus. So
Yeah, absolutely.
yeah.
And she, you know, just like many patients that I'm sure you see as well, have been to so many doctors. You know, the average, at least with endometriosis, is an average of at least 3 physicians and 10 years until diagnosis.
Right.
For her, I think she checked off at least 10 doctors that had been seeing her and treating her. Her list of medications was so long, and, you know, years of struggling. So those statistics are always in my head when I see patients. And 20% of hysterectomies are done for benign
Right.
disease, you know, for pelvic pain that may or may not relieve the pain. Often, yes, the uterus is the issue, but frequently it might not be.
Hold on one second. Let's take a pause here.